Yes, well, I started this master's program 7 years ago. So I understand there are several fellow candidates in the room. And so it's just an encouragement to say that if I can do it, you can do it, that's for sure. And I would like to acknowledge the tremendous support of this program to working full-time, busy family doctors, because otherwise, obviously, I think in any other program, I would never have completed. And I would also like to acknowledge the generous support of the Georges Lachapelle Scholarship Foundation, which gave me support as coming from Quebec. So coming from Quebec to do this program here has been something very special. And of course, right off, I would like to express my deepest appreciation to Moira Stewart for her mentorship, and as I wrote in the thesis, and as I told her, her always cheerful assistance. That's certainly one characteristic of Moira. So yes, this is, I'm going to attempt to, in less than 20 minutes, to give you a sense of what is in this thesis. You'll see why I have this, there's a few pictures of my companion in writing, who is our family cat, aptly named Bijou. And she was always on my bed beside my computer in different positions on the thesis. So, and in the lowest moments, she would put her paw on my shoulder and really give me some encouragement. So. Okay, so this public lecture will follow the usual outline for presentations. The thesis contains two studies, one for students and the other with medical teachers. And the final chapter integrates the findings from the two. So I've drawn from different aspects of the thesis to try and give you a sense of it. I wanted to start with a bit of background. Who am I? Well, Moira has already mentioned it. Yes, so I've been practicing in Chicoutimi for the last 28 years, and I've been fortunate to have developed a very full academic career in a regional site. That's a whole other topic of discussion. But still, there was a certain midway or midlife point where I realized that I had more behind me than I had ahead of me in every sense of my life. And so I got to thinking and asked myself a lot of questions. What matters most to you? What concerns you about medicine? And I realized that I wanted to work in this field for the rest of my career. Not only in this field, but I wanted to work in this field. Towards the integration of spirituality and medical education. For me, there was there is a link between the frustrations that I see with patients and with physicians that I feel about certain things happening in the system and in their experience that I felt with the lack of integration of spirituality in the medical arena. So that already off the bat I can say that's sort of my bias or my approach to why I chose this topic. A little bit of context very quickly. So this is Chicoutimi. In the back you have a majestic Saguenay fjord. How many people have ever been to? Oh, yes, great, okay. So if you zoom out from the room with the cat, this is our house with the orange roof right in the middle. In front is I don't have a thing, it's not necessary. In front is the hospital with the clinical teaching center here. Here's the family medicine unit here. And back up the hill is the local university with here the Saguenay Medical Program, which I direct. So my point is that I'm implanted right in the heart of Francophone Quebec. How many of you have heard of the mayor of Saguenay? Okay, well, you'll ask me that, that's good. This is the end of the interactive part of this presentation. Okay. So literature, a look at the literature. A quick review, obviously. There's a growing body of literature since the late 1990s, a groundswell of interest. No clear definition of spirituality. RS refers to religion/spirituality, and it's often a term that you will find in many studies. I mean, there's no distinction even made in surveys and so on. It's, what do you think of RS, for instance? Positive health outcomes are, in the literature, somewhat controversial, and that has not been the focus of my thesis. Often related to studies on the effect of intercessory prayer or the better health status of churchgoers, often U.S. studies, most studies are U.S. What else is in the literature? Patients want to be asked, 60 to 70% want to be asked about their spiritual needs, but there are gaps between physicians' attitudes and practice patterns. So that has also been documented in some studies, where physicians, the majority of physicians think it's important if they're asked, but very few actually ask their patients or talk about it. There are studies that show, mostly in the US, that physicians are less religious than in the general population, and even some indications that academic physicians are also less religious than physicians in general. Spirituality and medical education. Studies are mostly from US schools, and what has been written from surveys is that over 84% of US schools in 2008 had incorporated spirituality in some form or another in their curriculum. Now, it sounds very impressive, but at the same time, when you read a bit more, most of them are elective courses, or the word may be mentioned somewhere in a curriculum, but it's very, very variable. There's no clear educational approach. The focus is on spiritual assessment and experience with hospice chaplains. I don't know if you've heard or seen that there is in the literature a number of models for spiritual assessment, spiritual inventories, just like you would do a mental health assessment or other review systems or whatever. So that is taught in some schools. There are a few studies with teachers. Here, I'm going to move this. There are a few studies with teachers, mostly surveys. A few studies with students. They're mostly course evaluations, course satisfaction, and so on. And the other thing that is found in the literature is a bit of conflicting discussion over the role of evidence of positive health outcomes. In other words, does it matter? Is it important? Some approaches are, because if you have more spirituality, you are more healthy. That is why it's important in medicine. And for other people, that's not what's most relevant. Same thing for ideal timing in the program. Some studies talk about the earlier the better, and then others say, well, it's only when you're in clinical practice and even in residency that you start to actually, this starts to make any sense, it seems for a All right. I am speaking faster than my usual Zen self, and I'm used to speaking in French, so I think we'll get there. So the purpose of this study is to address some gaps as in the literature, to do a Canadian study. It was to do a Canadian study in a Francophone context, to help clarify the definition of spirituality and explore perceptions of medical students and teachers about the role of spirituality in healthcare and the integration of spirituality and into medical curriculum. So these are the research questions, which are essentially what I just stated, plus the last one. What educational activities can assist students to integrate and apply spirituality to their future professional practice? Okay, so a word about qualitative methodology, because as many of you are learning on site right now, you do have to look at what your research questions are and choose the right method that fit the questions. And qualitative methodology is an ideal methodology for when wanting to look at perceptions and understand the meanings that participants, that the people that you're studying, what they give to their experience and their perceptions. When you're researching a complex topic, and one that is very personal, and also when you are looking at a newly researched topic, so there's not really much around it, not much to hang your hat on to do a survey. Within qualitative methodology, different methods of analysis were looked at and learned about by the principal researcher. And simply put, what I find helpful is to say that grounded theory is very much about how something comes about, trying to construct a conceptual framework, and that would be the goal of your analysis. If you use more phenomenology, the goal of your analysis is to really understand why people say certain things or express things in a certain way. Whereas descriptive thematic analysis, which is what I used, is a more fundamental, it can be a bit more simple but not simplistic, and that is basically to describe, to say what have people said, by who, with whom, when, where, etc. So that is what we chose. So 2 qualitative descriptive studies with students, 6 focus groups, with teachers, 11 in-depth interviews, 1 francophone medical school, 3 academic sites, audio taped in French, translated into English, that was a challenge, and the appropriate ethics approval, of course. Trustworthiness and credibility, it's important to mention it because this is how one ensures methodological rigor in qualitative studies, and it corresponds to the concept of validity in quantitative studies. So we had maximum variation of the listed variables. Semi-structured interviewing is important because it's used in both focus groups and the depth interviews because it allows flexibility and modulation of your basic questionnaire guide to really try and get at the richness of what people want to say. Team thematic analysis was really important for rigor and making sure that we haven't forgot anything in the data or that truly saturation of things has been met. Repeated cycles of immersion and crystallization. So I don't have time to go into the whole details, but it's really about immersing yourself in the data, reflecting, and really seeing how it comes together in terms of the actual thematic categories that you can think about and then you continue to modulate as you work. Field notes by principal researcher. I mean, you don't always have to have them, but I really did take field notes during the interviews, after the interviews, read them, after listening to the interviews, after reading the transcripts. Analytic preconceptions noted. I sort of referred to it at the beginning, and there were others. I think it's very, very important to look at myself and say, well, what are your biases in this? And we also did back translation of selected excerpts to try and make sure that our translation was good. Okay, so yes, that's the line on the student paper, and then so the student sample, there were, as I said, 6 focus groups, 26 participants. What I did was that we had 4 groups with 73% of the participants were from 1st and 2nd year medical school. 27% of the participants were in the 2 other groups of 3rd and 4th year. The average age was the same for the 2 categories, 23. The gender corresponds to the gender differential in medical school. And what is maybe striking for you in London, living in Ontario, is that The 100% Caucasian, 92% Francophone, the other 8% is Anglophone. And 50% Roman Catholic. But what's important to realize is that several people put Roman Catholic, but in brackets, non-believer, non-practicing. So I mean, it basically is cultural, which means that if you take ones from both categories, 61.5% actually of the students said they had no beliefs. The teachers, there you have the average age, the range, the gender of the teachers. A bit more than half were geographical full-time, the others were clinical teachers. And just to mention about how the samples the sampling was done, the students heard about it and volunteered for the focus groups, whereas the teachers were contacted by myself. So there was a bit more of a selection there. People that I knew to try and reach the maximum variation of all these variables. A bit more than half had health education training, so they did not have masters, but they had done some coursework and so on. And again, 100% Caucasian, Francophone, and listing Roman Catholic. And again, most of them, however, that said they were Roman Catholic, said they had spiritual beliefs. So there's a bit of a generation gap, which we can talk about later. Okay. So, moving on. Sorry, I think I went too fast on that. Just go back to this. Sorry. Okay, so some of the findings. When it comes to the concept of spirituality, teachers definitely stated that spirituality for them was different from religion. It could include religion, but it generally was broader, more universal. For students, there was less distinction. Many of them just used the word, both words, religious spirituality, without making a distinction. And there was more negativity associated, perhaps, with certain rigid religious practices, and some even recounted more negative personal experiences. So, some verbatim. Teachers, for sure, religion is still part of it, in my mind. But I can see that people can live their spirituality without necessarily having that more religious aspect to it. Students, for me it's difficult to disentangle spirituality and religion. For me it has always gone together. So continuing on with the concept of spirituality, for students it was more personal. The concept of the an anchor in daily life, a framework helping to make decisions. For teachers, and this was for themselves and their patients, those two identities, whether it was as a person or as a physician, speaking of people in general, those merged. And they talked about 3 dimensions of relationship. The inward, the relationship with oneself, the outward, the relationship with others, and the upward, the relationship with something greater. Students, something you can hang on to when you're somewhat at a loss and you don't really know which way to go. Teachers. Now this extract, it was hard, there are many extracts for each something. But this extract was what I chose to try and give you a sense of what came out, which was very rich. It has happened to me occasionally to talk with patients who are dead and ask them to help me. To tell them, I helped you with that, I accompanied you in that. Now I need you to be there. Then I drew upon their strength that helped me to help other people. So initially, that extract for me, I had, coded as looking to a greater force. It's not necessarily God or belief in God, but looking to upward or to someone who has passed on. But I also found that I think that you can also see that there's this sense of then, after turning upward, turning inward, and then using that to help others to turn outwards. So that sort of illustrates the kind of things that people were saying, the teachers were saying. Okay, moving on to another theme, personal maturation. So here spoke of turning points. They told many stories of questioning family beliefs and arriving at a very sudden point where they had rejected them, or they had to decide what they believed in. And some of these stories were very emotional, and again, tears and dramatic, with even some telling stories of being rejected by their families or having to distance themselves from their families. I can't help but do a bit of editorializing. I didn't expect to see this at this. Certainly, it was quite something to live through with the students at this in 2000 and something, right? So for teachers, this was a different question. Personal maturation was one of a long, longitudinal inner journey through time, nourished by spiritual practices, punctuated by certain events, often with crisis and difficulties, that would trigger questioning and search for meaning of those particular events. So, to illustrate, it's because the child who is baptized, who since he was very small has been imbued with a religion, for sure at one point he will more easily adhere to that religion until the day when you decide to say, okay, certain things were instilled in me, but now does this satisfy me still? Does it make sense in my life, and can you very profoundly change your beliefs? But teachers, is there one outstanding event? No, not really. I'd say it's a continuation, a journey. Okay, so I'm going to have to go quickly, but here is an example of one of the figures in the thesis, which is a figure, a diagrammatic representation of these themes, especially as the teachers were able to express. So you have the inward, the upward, the outward, the journey, and for instance, starting from childhood beliefs, going all the way to death, confronting death, and the process of questioning and search for meaning triggered by crisis and difficulties and illness. Okay, so then there's the parallel with professional maturation. So I'm going to do a bit of students and then teachers. So for students, in their professional maturation, they were faced with a dilemma: commitment to scientific rationality versus their growing awareness of the effects of thoughts and feelings on illness and the power of the mind and strong belief. And this was because even in the beginning, when they met patients, they experienced certain events that caused them to be faced with this dilemma. You know, we always talk of evidence-based medicine. We don't talk of evidence-based spirituality. I want to believe that spirituality helps. It's something that, whether there are studies or not, I don't care. Maybe there are studies or not, I believe enough. Whether there are studies or not, I believe enough. It's maybe the only part of my life where I'm not rational. But you can tell they're not necessarily comfortable with the fact that they're not being rational. For teachers, teachers, simply put, as seasoned clinicians, spoke about the evolution of their convictions based on experiences with patients and unexplained events, leading to progressive shifts in paradigms of disease and illness. This is a bit academic jargon, maybe, but I will illustrate it. I mean, basically, they told stories spontaneously, to my surprise, of miracle cures, dreams, premonitions, strange coincidences in their practice. I've experienced things during all that time with my patients personally that make it that I am not the same person. Lots of people would say that it was coincidence. I think he had been 2 years with the same treatment. It did not work. We started to pray for him, and then he got out of it. In my opinion, there was something there. So I think that prayer may have affected the course of his illness. So this is again using the same kind of figure where you can see the professional journey. The idea being you start somewhere with your sort of traditional beliefs or that come from your practice and your training. Spirituality is taboo. I'm going to address that in a minute in medical culture. And then from there, you experience all kinds of situations, unexpected situation and events with patients in a reciprocal relationship that cause questioning, search for new models, and a paradigm shift. To go a little bit more in this physician role with patients, students had the dilemma, we're facing another dilemma, engagement versus proper distance, whereas teachers spoke of deep connections with patients, and that the patient-doctor relationship is of central importance to healing. So I think I may have to skip these quotes because we won't have enough time. But here they're speaking of this dilemma. And for teachers, I'll read this one. If we live our spirituality, we bring it into what we are as a physician. And we offer it like an entire package to the patient. For me, when I care for a patient, when I care for my patients, somehow one of the things I try to do is connect with them on a spiritual level. Okay, so I'm going to end with a little discussion of the implications for medical education. You see here the barriers that both students and teachers spoke of when it comes to integrating spirituality into medical education. And these are some of the barriers that only students spoke of, and then only teachers, well, mostly, students and then teachers. And I particularly want to draw your attention to this issue of spirituality being a taboo topic in medical culture. So teachers say, the main barrier is the fact of having difficulty with first saying the word. When we speak with our students, we will say the word spirituality and they will look at us. I think it is being able to say the word and say, look, this is spirituality and we're going to discuss spirituality and have an open mind. So there was a sense that like sexuality used to be, or maybe ethics, this is sort of the new frontier. In terms of facilitators, these are the facilitators that both students and teachers spoke of, and I don't have time to go into them, but I want to draw your attention to the importance of stories because they spoke a lot about them. We want to hear stories. We want to hear about stuff. I think that using patients to do certain kinds of workshops or meeting with students, I'll skip to the end, it's not the same thing. I think that telling students about spirituality is not the same thing as having patients come and tell their story. Here are some of the facilitators spoke of just by students, spoke of just by teachers, and specifically students spoke of, yes, meeting patients, but as early as possible. So I'm going to go ahead with that. Oh, did I go too fast? I did. Okay, so in summary, for the student paper, this was what came out in the discussion of the thesis. The three dilemmas. So separating them out again, teasing them out. The turning point in young adulthood, which certainly relates to Erickson's developmental stages and other authors. The challenge of engaging with patients, which also is congruent with the literature on professional maturation, physicianship, as well as narrative medicine. And the dilemma of science in medicine, which relates to the traditional Cartesian mind-body schism. Summary of the teachers is the central role of the patient-doctor relationship, with which, for us in this master's program, is something that we're unaware of, as it's a central component of the patient-centered clinical method for family physicians. Gaps between belief and practice. The teachers spoke about what was in the literature, it correlated with what was in the literature, and especially the difficulty in talking about spirituality. And this idea of the personal and professional journey, which again, if you haven't heard about Kuhn here, well, I certainly did, at any rate. Discussion, implications for medical education. I'll let you read this. This is sort of what we teased out through these studies as the implications for medical education. A word on strengths. I think that there are the methodological rigor is the strength of these studies, of this whole research project. The fact that it was a Canadian study, a francophone context. I didn't mention, but I only found 4 Canadian studies in about spirituality and medical education, and none in French or none in surprising depth of the medical students. There are many things we're touching. Richness of teachers' experience, almost secret experience that they had never shared with anybody. And hopefully a worthwhile contribution to the literature. The limitations, well, there were a limited number of participants in some focus groups, which I can discuss in the question period if you want. Participants, obviously there can be a participant selection bias, especially with the teachers, but it can also be self-selection with the students. The challenges of translation, all from the same medical school, and has certain homogeneity. Well, that's an understatement. So therefore, the findings may not be transferable. They may relate to a particular cultural context. But for me, that is very valuable because I work and live and want to, and I'm in a position of being able to enact change in my environment. So this has been very rich. Implications for future research. Is this a useful conceptual framework, the thematic map that you saw? And then obviously more studies would be needed, perhaps elsewhere in Canada. Even in the States, as I said, more studies are needed, the actual perspective of students and teachers. Conclusion. These findings point the way to recommendations for a renewed educational approach to teaching and learning the practice of medicine from a holistic and integrated point of view, congruent with current recommendations for curricular change and reform in Canada and in North America and even around the world at this point.
So we have a little bit of time for maybe 2 questions.
2, yes.
We don't have unlimited time,
No.
so if you have a question, please come forward now and ask Dr. Hatcher about her study, her 2 studies.
I find it actually quite interesting because what it brings to mind for me is these students. I wonder if their perceptions pre-existed their medical training, or if there's a hidden curriculum that kind of makes them push the importance of spirituality aside. Like the fact that our curriculums don't talk about spirituality, they probably don't have role models that talk about how they talk about spirituality. So I noticed that you did have 1st and 2nd year students and 3rd and 4th year students. I don't know if you looked at whether there was a progression or a change in attitudes between those 2 groups, or...
Thanks for the question.
That's a very good, yes. It's a very good question. Yes, I looked to be sure, is there something that, because I could have maybe come up with, that there was a difference between the 2. And with all the things, that really was very similar. The only difference I would say is that in the 1st and 2nd years, it's felt that lack of contact with patients much more. The 3rd and 4th years mentioned it, but they were able to relate a few more stories of experiences they were having. But the themes, in terms of a difference in themes or approach or way of viewing it in our analysis.
Good question. Others?
I really enjoyed that, actually. I had never really thought of that subject myself. One thing that struck me about the distribution of both the teachers and the students was that although a large number of them said that they were Roman Catholic, in fact, most of them had actually had religious beliefs. So to me, that kind of smacks a little bit of people with tensions going on in their lives, sort of, you know, this personal tension about do I accept spirituality or not. And have you thought about how that might have impacted on your findings? I mean, to me, it suggests that they would have been very rich, but I don't know if you have any
Well,
thoughts.
definitely, yes. I'm glad you asked the question because I didn't have time to really include it in the presentation, but it's included in the discussion of the thesis. I have suppose, and it is one of the hypotheses, that definitely there is a link in that the Francophone Canada, and it's not just Quebec, has undergone well-known complete transition, like a complete backlash towards the Catholic faith, which is the majority there. So that what you have in the statistics is that officially they will say there's a strong attachment. They will say 83% say they're Roman Catholic, sort of like in this study, but only 20% go to church. And when you look at the young generation, it goes down to 7%. So it's definitely this whole cultural thing, but a lot of tension. And it came out also, that's what was surprising to me, is these young students, I mean, these are, 19 to 25-year-olds, are experiencing not just historical tensions that are in the environment, but tensions still in their families. By taking a stance, that the stories are, I was religious and then I went to medical school. And in medical school, and I went to university. And in university I discovered science. And then there was this conflict between religion at home and science in school. And so much more than I had anticipated or thought.
Excellent. Well, on your behalf, I'm going to thank Dr. Hatcher for her explanation of her thesis, and so far so good.